everyone, it's Dr. Hall. We're going to start cardiovascular part 2 lecture, which is about blood pressure and about blood vessel anatomy. So last time we talked about vessels themselves. So we talked about the arteries and their mini-me's, the arterioles. We talked about how arteries have a thick middle layer that has both elastic and smooth muscle tissues in it that allows it to withstand the high pressure environment of the arterial system, as well as to modulate or customize blood flow and send more blood to the places where it's needed by relaxing smooth muscle and opening up those vessels, or reducing blood flow to a certain region by constricting the blood vessels, right, by contracting that smooth muscle. We also talked about capillaries, which are the smallest vessels, only one cell layer thick in their wall with those very thin, flimsy, simple squamous epithelial cells that allows for diffusion of solutes down their concentration gradient from an area of high concentration to low concentration. So oxygen and glucose can move out of the blood and out into the tissues, and waste products like carbon dioxide and lactate can move out of the tissues and into the bloodstream. We also talked about how fluid, water primarily, also moves out of the bloodstream and then back in as a result of two different types of pressures. Hydrostatic pressure, which is just the pressure of the fluid inside the blood vessel walls, which tends to be high toward the arterial end of the capillary bed, and then osmotic pressure, which is the pressure of the dissolved solutes that will make water tend to move inward. As fluid gets moved outward at the beginning part of the capillary bed, that increases the concentration of the solute, so by the time we get toward the venous end of the capillary bed, osmotic pressure is high and pulls the fluid back in. We also talked about veins and how they're relatively flimsy from a structure standpoint, and that's a good thing. They don't need to withstand high pressures, and they also need to be squishy. In order to maintain the one-way direction of blood flow, veins have specialized structures called valves that are found inside of them. There are two main ways that blood travels through the veins to get back to the heart. The first is the skeletal muscle pump. When muscles contract, they increase in diameter and squeeze nearby veins, and the blood can only move in one direction because of the valve, so it moves toward the heart. And the respiratory pump, which is that negative pressure or suction created when we take a breath in that not only pulls air into our thoracic cavity, but also pulls blood. All right, so we're going to start by talking a little bit about regulation of the cardiovascular system. Understanding that we haven't talked about the heart yet, we're going to do that next week. We're just going to talk about something that primarily is a factor in the blood vessels themselves. And so that is blood pressure. So when we talk about blood pressure, we're really talking about the hydrostatic pressure of the blood in the vessels themselves, right? They are a container. And so how much pressure is being exerted? And so of course that pressure is going to depend on the volume of blood and the size of the container, or in this case, the diameter of the blood vessels. So we need to have some blood pressure, right? We talked about it before. We need to make sure that we have enough pressure in the hose, so to speak, for the blood to get to all the different parts of our body that it needs to reach. It needs to combat gravity. It needs to get far out to the tips of your fingers and the tips of your toes. So we need enough pressure to make sure that it can do that. But we also need to make sure that the pressure is not so high as to cause damage to that inner endothelial lining of our arteries specifically, which we talked about last time as being a significant risk factor for atherosclerosis. So when we talk about blood pressure, there are two numbers that we use. The first number, which is normal, is 120. Ooh, that's yucky looking. All right, but anyway, is called the systolic pressure. And so that pressure is the pressure that is exerted by that pulse of fluid being pushed through the blood vessels when the heart pumps, right? So every time the heart contracts, so during cardiac contraction, which we call systole, I always remember it as systole for squeezing, that is our systolic blood pressure. And then we have a second number, which is the pressure when the heart is relaxed in between each beat, and that's called diastole when the heart is relaxed. So that's our diastolic pressure. So blood pressure is expressed in two numbers, right? So the classic normal is 120/80. 120 would be the systolic pressure, which is going to be higher because that's when the heart is pumping, and diastolic of 80. So of course we need to maintain homeostasis, right? So anytime we need to keep things within a fairly well circumscribed levels, we need to have systems to monitor and make adjustments as needed, right? So we need to keep things in balance. So let's look at the factors that influence blood pressure. So the pressure of a fluid in a container is always going to depend on how much fluid and what's the size of the container. So when we're talking about what's happening, especially during systole and how much fluid we're dealing with, that depends on how much the heart is pumping through with each beat. So how much blood is the heart actually pushing through, which would be the stroke volume, which is the volume of blood during a heartbeat, and then how rapidly is the blood being pumped through the system, right? So how many times per minute is your heart beating? So blood pressure is going to depend on how much the heart is pumping and how quickly the heart is pumping. It's also going to depend on the diameter of the arteries, because that's what influences the size of the container. That's what determines, there we go, the size of the container, right? So, oh, sorry, I didn't animate correctly. But anyway, the diameter of arteries is controlled by the smooth muscle in the arterial walls. So when the smooth muscle contracts and we have a smaller lumen, a smaller opening, we call that vasoconstriction. And when they relax and open up, that's called vasodilation. So obviously we need to have a sensor. We need to have something that tells us what the blood pressure is. So we actually have these really interesting things called baroreceptors. And we have some in our carotid arteries, and we have some in the aorta. So these are specialized areas that will sense blood pressure, and then they report that information up to the central nervous system, specifically to the medulla oblongata, which you might remember as the part of the brainstem that's important for life support functions, right? Blood pressure, heart rate, breathing, that's the medulla. So the medulla oblongata, here it is in the brainstem, is then going to activate the autonomic nervous system. Because remember, the autonomic nervous system is the system for motor activity of our organs, right? So these involuntary automatic control of our visceral organs, so including heart and blood vessels. So the autonomic nervous system is what is going to be activated. So you might remember this diagram of the autonomic nervous system. So the sympathetic nervous system, that's our fight or flight. And the sympathetic nervous system is going to send its signals down from the brain, and then they are going to travel through the sympathetic chain right here, okay? So that's going to use the sympathetic chain. And another interesting thing about the sympathetic nervous system is that it uses norepinephrine as a final neurotransmitter. So when you think about epinephrine, right, your fight or flight response, that's where that's coming from. The parasympathetic nervous, oh, I'm sorry, I wanted to say one more thing. So if you activate the sympathetic nervous system, that is going to tell the blood vessels to constrict, right? So we're going to make the container smaller. That's going to increase the pressure. We're also going to send signals to the heart to speed up and to beat harder. So we're going to increase our stroke volume, how much blood is getting pumped out through the heart with every beat, as well as how many beats per minute. So that's what we're going to do for the sympathetic nervous system. If we're going to activate instead the parasympathetic nervous system, that's our rest and digest. So most of the effects of the parasympathetic rest and digest system on the heart and the blood vessels is simply that we've turned off the sympathetic. So you might see here that the only thing that the parasympathetic division does is it can slow down the heartbeat, right? It doesn't directly tell the heart to do anything about how hard it's contracting. It doesn't directly tell the blood vessels to open up, right? We've just turned off the sympathetic nervous system, so those things happen automatically. So the parasympathetic nervous system, also remember, we don't have a sympathetic chain. The ganglion is out near the organ. So most nerve signals in the parasympathetic nervous system are traveling through this vagus nerve. And the neurotransmitter that we're going to use for parasympathetic is acetylcholine. Nice little review there. So in summary, there's going to be some sort of change in blood pressure where we're like, oh, it's not what it needs to be. So our baroreceptors in our aorta and in our carotid arteries are going to send signals up to the medulla oblongata, which then is going to activate one or the other branch of our autonomic nervous system. If blood pressure is too low, then we're going to choose the sympathetic nervous system. We're going to speed up the heart rate by telling the SA node to beat faster. We're going to tell the ventricles to beat harder, and we're going to tell the arteries to constrict. So that is all going to increase blood pressure. If, on the other hand, blood pressure is too high, right, then again it's going to be sensed by the baroreceptors in the aorta and in the carotid, going to send the signal to the medulla, which is then going to activate the parasympathetic nervous system, which will tell the heart to slow down. In the absence of the sympathetic system being activated, the ventricles will go back to being more chillaxed, and the arteries will also relax as well. So again, if blood pressure is too low, who are you going to call? Sympathetic nervous system, but I didn't have that planned. All right, so we're going to tell the medulla oblongata that's going to activate the sympathetic nervous system, which is going to use the neurotransmitter norepinephrine, send out via the sympathetic chain, and we're going to tell the blood vessels to constrict. We're going to send signals to the heart. We're going to tell the heart to beat faster and to beat harder. And so blood pressure will get higher until everything goes back to normal. On the flip side, if blood pressure is too high, we're going to signal that, right? We're going to sense it. We're going to tell the medulla, which is going to shut down the sympathetic nervous system and turn on the parasympathetic nervous system until blood pressure gets back to where we need it. This is that same information in a chart, because sometimes I think it's nice to have it in a table format. Now I'm going to take the opportunity to go through some basic blood vessel anatomy with you, because there's a lot to it, and sometimes hearing me talk through it can be useful. Usually we draw this on the board in class, but you know, so here we go. So first let's start with the aorta. So the aorta is the big artery that is coming out of the heart, bringing freshly oxygenated blood from the lungs, up out of the heart on its way to the body. So this first part, because it's actually going up, is called the ascending aorta. Then it's going to curve, so we call it the arch of the aorta, and then it goes down, so we call it the descending aorta. So that part makes sense. Just be sure on your quizzes and things that you pay attention and you see, are you at the arch? Are you in the ascending part? Are you in the descending part? The trickier thing is then these three branches that we see coming off the aortic arch. So the first one is the brachiocephalic artery. And if you break that word down, brachio means arm and cephalic means head. So this is the arm-head artery. So this artery is going to carry blood out to the right side of the body that's going to go up to the head and out to the arm. So the artery that's going to go up towards the head and neck is going to be the right common carotid, and the one that's going to go out toward the upper extremity is the right subclavian artery. On the left side, the common carotid artery, which is going up towards the head and the neck, gets its own branch off the aortic arch, and the subclavian, which is going out to the arm, gets its own branch off of the aortic arch. The reason for this is that on the right side, there's a really big vein located. Let me just give you an idea here. There's a really big vein that's, oh, that's terrible. Here, there's a really big vein right here, and that's called the superior vena cava. And so there's just not a lot of room over here on the right side, so that's why we needed to have the brachiocephalic artery or brachiocephalic trunk to make us a little bit of, get us out of the traffic jam before it actually splits into two other arteries. All right, the final thing I want to leave you with for this one is the way I remember these arteries is I remember A, B, C's. So I have my aorta, then the first artery to come off is my brachiocephalic, then my common carotid on the left, and then my subclavian on the left. That's how I always remember those. Now, as the aorta continues down inferiorly, it's going to go through the diaphragm and enter the abdominal cavity. So what we're looking at right now are all the branches of the abdominal aorta. So the first artery that you need to know about that comes off of the abdominal aorta is it's a trunk. So a trunk is like one of those exits in Chicago where it's like exit here for this highway and this highway and this highway, and they get you kind of out of the city a little bit and then you further subdivide. So the celiac trunk is the same way. The celiac trunk is this big exit, and then it's going to branch into three arteries that are going into different places. So coming out here to the left is the splenic artery going to the spleen. No big surprise there. Then we also have the common hepatic artery coming over here that's going to go toward the liver. And then finally the left gastric artery. And what I don't like about this diagram is it should be shown moving out to the left side because your stomach is over here on the left side. All right, so this is getting messy. Okay, there. So our first branch off was the celiac trunk, which split into the left gastric, splenic, and common hepatic arteries. Next, on our way inferiorly and the abdominal aorta, we have a pretty big artery called the superior mesenteric artery. The superior mesenteric artery is going to supply all of the small intestine as well as about half of the large intestine. So it's a really big artery. Next, coming off the aorta, we have renal arteries. Renal means of the kidney. So we have the left and right renal arteries. As we continue farther down the abdominal aorta, we have two arteries going one off to each side. Those are the gonadal arteries. Gonadal is the non-specific term that can be referring to either the testicles or the ovaries. So if you don't know what type of gonad somebody has, you just say the gonadal arteries. And those are paired. There's one on each side, just like the renal arteries. And then finally, our last branch off the abdominal aorta is going to be the inferior mesenteric artery here. And so the inferior mesenteric artery is going to supply the other half of the large intestine. Continuing downward, we can see that the abdominal aorta is going to bifurcate or split into two. And so each one of these heading out to each side are called the common iliac arteries. So anytime you hear the word common, you know it's then going to split into other things. And so in this case, each common iliac artery is going to send off an internal iliac artery, which is going to supply the pelvis, so the urinary bladder, reproductive structures, and an external iliac artery, which is going to continue down into the lower extremity. So we have our common iliac arteries, and each of those branches into an internal and an external iliac artery. I want to take a moment now to show you some of the circulatory system for the head and neck. And this is a little bit limited, but we'll do our best. And then we're also going to look at going out into the arm. So you'll remember we have our brachiocephalic trunk right there. I just highlighted it with a green dot for you, which is going to send off your right common carotid. Our second branch off the aortic arch was our left common carotid, right? And then our left subclavian with those green dots there. So as we follow the common carotid arteries up into the neck, they are going to split. So one branch is going to continue up and go through a hole in the skull to supply the brain. That's going to be your internal carotid artery. Another branch is going to split out to the side and supply the face and the scalp. That's the external carotid artery. So your common carotid arteries split into an internal and an external. We also have additional arteries to supply the brain, the vertebral arteries, which you can see right here. So you might remember when we studied the skeleton that we had those transverse foramen in the transverse processes of the cervical vertebrae. The vertebral arteries actually travel through those little holes. They ascend up toward the brain and they come together in the basilar artery. So in terms of blood supply to the brain, you have your common carotid, which sends off the internal carotid, which is going to supply the brain. And then you also have your vertebral arteries, which combine into the basilar artery, which is also going to supply the brain. What's not shown here in this diagram is that there's a traffic circle of blood vessels on the bottom surface, inferior surface of the brain called the circle of Willis. Oh, that's terrible. And the circle of Willis acts like a traffic circle so that if one of the vertebral arteries or one of the internal carotid arteries gets a little bit blocked for some reason, you can still get blood flow to the brain. All right, I'm going to get rid of that. So let's now take a look at the circulation heading out. Oh, let's stay with the head and neck and let's do veins. So you know how we had internal and external carotid arteries? Well, we also have internal and external for the veins, but they're not called carotid. It's kind of weird. They're called jugular. And then the other difference with the veins is that there is no common jugular vein. So we have the external jugular vein coming here that's draining the face and the scalp. And then we have the internal jugular vein coming down here, which is draining blood from the brain. So now, let's go out into the upper extremity. So if I look at the right side, here's my brachiocephalic trunk, sends off a common carotid on the right, and then it continues as the right subclavian artery. It's deep to the vein here, so it's a little hard to see. As this artery travels distally, it's going to move through the armpit, and we call it the axillary artery. It hasn't branched or anything. We've just changed its name just to be mean. And then as it continues down all the way into the arm, we're going to change its name yet again and call it the brachial artery. So confusing. So we started as the brachiocephalic artery on the right side, but on the left side you just start as plain old subclavian. And then as you get into the armpit, you are the axillary artery, and as you get out into the arm, you are the brachial artery. That then will divide when it gets to the forearm to one artery over here on the side of the radius, so it's called the radial artery, and another artery here on the side of the ulna, so it's called the ulnar artery. Let's look at the veins. So the veins draining blood from the upper extremity. On the radial side, we have the cephalic vein. And on the ulnar side, we have, do they label it here? The basilic vein, there we go. Right? And the cephalic vein continues all the way up right? And it's going to dump into your subclavian vein. All right, and the other thing that I want to show you is right here is the median cubital vein. This is a vein that connects the cephalic and the basilic veins, and it's actually the vein that usually when they draw your blood, that's usually what they're drawing your blood from. Before we move on, I just want to say that the cephalic vein, the basilic vein, and the median cubital vein are very superficial, right? You can see those through your skin, especially if you're somebody who works out a lot. You can see those veins quite easily. They are very superficial. The other blood vessels here are very deep. They are not close to the surface at all. If we take a look now at the lower extremity, we'll recall that the aorta bifurcated into the two common iliacs, and then they sent off their internal iliacs and their external. As soon as we get out of the torso and into the lower extremity itself, so around here, now we call that the femoral artery. Again, it hasn't sent off a branch or anything, we've just changed the name. So now it's the femoral artery, but that's kind of easy to remember because it's along the femur. As that artery continues inferiorly, it goes behind the knee into the popliteal fossa, so we call it the popliteal artery. And then it's going to branch into two. There's one branch that's going to go along the anterior surface of the tibia, strangely named the anterior tibial artery, and another one that's going to go back behind, which is called the posterior tibial artery. So at least those make sense. As we look at veins, again, we're going to have an anterior and a posterior tibial vein, then a popliteal vein, femoral vein, and then that's going to drain into your external iliac vein, and then your common iliac vein, and then your inferior vena cava right there. Is there anything else? Oh yes, there's one other vein that's important, and it's different because it's very superficial. This is another one that's superficial that you can see relatively easily, and it is called the great saphenous vein. So the great saphenous vein travels along the medial lower extremity, and it's huge, it's enormous, it goes all the way down to your ankle, right? So it's a really long vein that is draining blood, again, into your external iliac vein. The great saphenous vein is often harvested if we need to do a blood vessel graft for somebody. So if somebody's having bypass surgery on their heart, for example, we're actually going to take their saphenous vein and basically turn it into an artery to supply their heart muscle. It's pretty crazy. And that's just another copy of this if you want to kind of print it out from the PowerPoint file. That's veins alone. And this is a basic diagram of blood vessels. So now I want to talk about some special, unusual circulations. First one is the cerebral circulation, circulation to the brain. I already alluded to this earlier, but let's take a closer look. So in order to get blood up to the brain, so we've got, do I have my tools? Yep. So we've got blood coming up, or maybe I don't. Let's see. Yep, coming up. So remember, the external carotid artery is just going to supply the face and scalp, but the internal carotid is going to go through a hole in the skull to supply the brain. We also have the vertebral artery coming up through the cervical vertebrae, which is also going to help supply the brain, because the brain is super duper important, right? So we want to make sure we have a really good system to supply it with all the blood that it needs. So we have both the internal carotid arteries and the vertebral arteries to supply the brain. They come together, as I mentioned earlier, in a traffic circle of arteries called the circle of Willis. So down here we have our vertebral arteries. They come together to form the basilar artery on the base of the brain. So that's a nice way to remember basilar artery. And that's going to enter this traffic circle of the circle of Willis. The other arteries that are entering in here are branches off of the internal carotid artery. So this gives us some backup, a little redundancy. So if any one of those vessels is partially blocked, then usually we can compensate relatively well. Another interesting circulation is the hepatic portal circulation, and this one's really weird. So, I forgot to animate something. But anyway, normally blood goes from the heart and lungs out through arteries, eventually gets to capillaries, then drains into the veins, which take it back to the heart, right? That's what we've been talking about, this one-way system. It's always artery, arterioles, capillaries, venules, veins, and then back to the heart. Well, portal circulations are weird. In portal circulations, you go from an artery to a capillary like you normally would, and then you drain into a vein like you normally would, but instead of going back to the heart, that vein goes into another capillary bed. Totally weird. And then those capillaries drain into another vein, which then takes you to the heart. So the circulation for the digestive system, which we call the hepatic portal system, is going to work this way. So let's think about why that is. First of all, a little review of the arteries that supply the digestive system. So they are branches off of the abdominal aorta, the superior mesenteric artery, which is going to supply half of the large intestine and all of the small intestine, and the inferior mesenteric artery over here, which is going to supply the other half of the large intestine. So the capillaries out in your intestines are not just supplying the tissues of your intestines with what they need, they also happen to be absorbing all of the stuff that we've been eating. So all the nutrients and vitamins and minerals, as well as all the toxins and things that we are eating and drinking. So this material needs to be processed before it kind of goes into the general circulation. We can't just dump all this alcohol into our general circulation and let it go all over our body. Or if you just had a milkshake, all those fatty acids and all that sugar, we need to process it and pull some of it out of the general circulation. So therefore, all of this blood from the intestines has to go to the liver before we can allow it out to the rest of the body. And this is just that information for the outline. So the veins that are draining this nutrient-rich blood from all of our intestines, the small intestines, which are going to drain into the superior mesenteric vein, as well as half of the large intestine, and then the rest of the large intestine is going to drain its blood into the inferior mesenteric vein. So we've got superior mesenteric vein here, inferior mesenteric vein here, also the splenic vein coming from over here, are all going to come together into this vein, which is going to bring this blood to the liver, and that's called the hepatic portal vein. So all of that blood is going to be brought to the liver for processing. I don't like the colors they picked here, right? So here's our hepatic portal vein coming into the liver. I'm going to color it purple, right? And so it's going to go out to little tiny capillaries in the liver, which are then going to process this blood for us, which is good because we need them to do that. And then once that blood has been processed, it's going to drain into what are called hepatic veins, right? So this nice processed blood is going to travel through hepatic veins and then enter the big vein that drains the inferior portion of the body, the inferior vena cava. So we had the blood from the capillaries of the intestines drained through the splenic vein, the superior mesenteric vein, the inferior mesenteric vein, into the hepatic portal vein, which then took it out into capillaries, and then it goes into the hepatic veins to get into the inferior vena cava. So summary, right? We talked about a lot of things today. So we talked about blood pressure and the regulation of blood pressure, how we have baroreceptors in the aorta and in the carotids that send signals to the medulla oblongata, which will then activate the sympathetic nervous system or the parasympathetic nervous system, depending on how we need to adjust blood pressure. Sympathetic nervous system will send signals to the blood vessels, the arteries, to constrict, therefore increasing pressure, as well as to the heart to beat harder, more forcefully, as well as more quickly, which will also increase blood pressure. If we need to decrease blood pressure, we're going to turn off the sympathetic nervous system and turn on the parasympathetic nervous system, which will send signals via the vagus nerve to the heart to tell it to slow down. Then we talked about anatomy, kind of went through all these different blood vessels. For most of them, right, the arteries and the veins have the same name, but not always, so be really careful with those jugulars. And I just noticed there's a mistake here. There is no such thing as a common jugular vein. All right. And then we talked about weird circulations, right? So we have that hepatic portal circulation where we take all the blood from our intestines to the liver for processing through the hepatic portal vein out into capillaries in the liver where it gets processed, then it drains through the hepatic veins into the inferior vena cava. We also talked about the circle of Willis, which receives blood from the internal carotid arteries as well as the vertebral arteries via the basilar artery to form a backup system for the brain. All right, I hope that makes sense. Send me your questions. I hope you're all doing well.